There we go. Okay. Hi there. Let's talk about some spine issues. And thanks everybody for sticking out to almost the end of the conference here. So when we talk about spine deformities, it helps to get our words, our definitions down a little bit. So a scoliosis is a side-to-side curve, whereas a kyphosis is usually it's in the upper back, and it's an exaggeration of the normal upper curve that we have in our back. And you can also have a lordosis, which is the typical curve we have in our lower back. The small of our back is a lordosis. But so if you were to take a kyphosis and you straighten it out too much, you actually get a lordosis of your upper back, for example. So different ways we can use those words. So what is a scoliosis? It's a rigid curvature of the spine. And the reason for treating it is, yes, to a certain degree, it's cosmetics, because everybody looks better if they don't have a curve in their back. And if the curves get really big, they can cause difficulties with balance and those kinds of things. But one of the big reasons for treating it is actually having to do with how well the contents of your chest does, the deformities that your chest can cause. We'll talk about that in a little bit. So different kinds of treatment you can do are you can cast a curve for the young kids. We can try to manage a curve with bracing, or then we have to go towards the more surgical type things, such as fusing a curve or trying to treat it with a growth-friendly treatment. So getting back to the treatment rationale, so we talk about if the chest size gets too small, then what's inside the chest can get choked off, and that can cause what's called cardiopulmonary compromise or heart and lung issues. And part of that is pulmonary insufficiency, which is where essentially the chest gets so deformed that the lungs get squished, and if they get squished, you have trouble getting oxygen into them, or you have trouble getting blood into them, or more importantly, the area where the blood and the oxygen are supposed to come together are mismatched. And so you're not able to get good transfer of oxygen into the bloodstream. And if that happens long enough, then the heart has a hard time getting blood pumped into the lungs. You can have something called cor pulmonale, and that is where the heart actually gets so overworked, it starts to really get bigger and bigger like any muscle would, and then it gets too fatigued and it starts not to work well. Now, mind you, this happens for very big curves. This is curves that are 80 to 90 degrees, although you can find some issues with breathing already in curves that are about 60 degrees or so. But this is the kind of thing that we worry about. So here's a cross section of a chest on a CT scan. And you see that this is where the lung fields are. They're pretty small. This is the heart here in the middle. Here you see the spinal column, the ribs on the side here. But this is the lungs. And in fact, this lung actually traces out over here. But this area over here, it looks kind of what we would call grayed out. That's because this is not healthy tissue over here. You can't get enough oxygen into it. The lung's not opening up. And you're starting to have some issues with getting enough oxygen and blood to mix at the same level to get oxygen into the blood. So scoliosis can be found at all ages. When we talk about it, we usually try to break it down a little bit into 3 age categories. So we talk about infantile curves, and that are curves that we see before about 3 years of age. Now, in kids who don't have arthrogryposis, kids who are otherwise typical, these curves can sometimes improve spontaneously. And sometimes they're related to just a kid who's very floppy, who's very flexible. So they sit, they kind of give themselves a curve that as they get stronger, they're able to work out. And arthrogryposis is a little bit different. We'll talk about that as we go along here. And then we have the juvenile age range. It's about 3 to 10. And a lot of the kids that are first diagnosed as juveniles probably had an infantile curve that just wasn't picked up earlier. And then you get the adolescents. And this is when you talk to most people about scoliosis. This is the kind of scoliosis they're thinking about. This is the young teenager who starts developing a curve that goes along with when they're getting into their puberty time. Now, what this age type thing doesn't talk about are a very common kind of curve that we see in arthrogryposis, which is the neonatal curves, the curves that kids are born with. Now, it's a little bit different, or it's a fair amount different from a different kind of curve that kids are born with. We call it congenital curve. So a congenital curve is a curve that has the vertebrae are incorrectly put together. So you don't have these nice blocks on top of each other. One of the blocks could be a triangle, so the bones go off in a different direction. Whereas in arthrogryposis, the spine is put together correctly, the bones are made correctly, but because the baby's not moving around a whole lot and they're in the uterus and kind of in this position along this line like so, that's what they're born with, is a spine that looks like the position they were in intrauterally. And this happens a fair amount. So in the typicals, a lot of these younger curves can go away, but we don't find that as much in arthrogryposis because these curves tend to be much more rigid. And again, they reflect the interuterine positioning. And they can progress relentlessly, or they can actually stay stable for a long time. And again, I'll show you that in a little bit when we get there. So when we're talking about curves in arthrogryposis, how do we treat them? And it's a little bit difficult to come up with good conclusions because there's not a lot written about it. And this is one of the things that a lot of us are doing studies on and trying to get more into literature to talk to each other more about it. And so essentially what I'm going to be talking about is my accumulated experience, and that keeps on changing over time. But certainly the mainstay of treatment for anything having to do with arthrogryposis and orthopedics is physical therapy. So we want the physical therapist very early on to be working with the babies. If a baby is born with a curved trunk, we want them to try to stretch that trunk out as much as possible. As the child gets stronger, we want them to do asymmetric exercises. So like you put them on a ball and you roll them to the side so they have to try to pull themselves over. Those kinds of things to try to get them stronger. Sensory integration type activities where they're having more of a sense of how their body is in space. And a lot of tummy time. So they're trying to, as the little babies, they're trying to pull their head up. And when they pull their head up, they're strengthening their back as well. When we have low-toned babies, we don't want these babies to be put into a sitting position until they're able to hold a sitting position themselves. If you have somebody who's got very low tone and you sit them up, they slouch and they crouch. And we don't want that to happen. So what we'd rather do is wait till the kids get strong enough that they're able to pull themselves up to a sitting position. So with those very low-toned kiddos, what we usually recommend is that they're always sitting at about a 60-degree angle when they're upright. So you can feed them and things like that, but they can lean into the seat that they're in. And again, you want to wait until they're able to pull themselves up more to a sitting position before you allow them to be at that for long periods of time. And then we can talk about casting or bracing for these kids. So here's a kiddo. Here he is at 2 months. You can see this big curve that he's got that he was born with. And you can kind of get the impression of how he was laying in his mom, where his right side was the down side. His left side was the side that was more upwards. And here he is a year later, and you see that same curve. And here he is up on his knees. But again, you get that sense he still has that same curve. In fact, if we look at his x-rays, on your left is him at 4 years of age, and on the right is him at 8 years of age. This curve really hasn't changed. It stayed pretty stable. Now he's more like about 12 years of age, and he's gotten to the point that the curve starts to progress, and we're going to have to do something about it pretty soon. But for a long time, he was stable, even without bracing or anything. But this was, again, a curve he was born with. Similar to this kiddo here. This is a curve that he was born with, a different curve. This is more of a hyperlordosis type curve that goes along his whole back. And this is one that he was born with. This is what his x-rays look like. So in the very young kids, we oftentimes will try casting. And I like to think of casting as an old technique that was reborn, because before we did a lot of the metal implants for spine fusion, and this was way before I came on the scene, there was a lot of casting that was done for spines. And essentially what you do is you would repeat casting until you got somebody about as straight as you could get them. And this could sometimes be a year or so. Then you go to the operating room, lay them on their belly, make a hole in the cast, and you'd operate through that hole to get down to the spine, rough up the spine, put a lot of bone graft down there, close everything up, you leave the cast in place, looking for the cast to hold them in a position as their spine fused. So luckily we're way past that, because that was probably not a very pleasant time period. But then the idea was, well, maybe we can use this on the very young kids to help correct out their curves. So initially, when I started doing this, it was only appropriate for kids under 3 years of age. But gradually over time, we've been increasing that age range, casting them into later ages when it's helpful for us. It's something that's done under anesthesia. And the usual schedule is, if you have a child under 2 years of age, we'll change the cast every 2 months. Between 2 and 3 years of age, we change it every 3 months. And over 3 years of age, we'll change the cast every 4 months. And what you're looking for is either that you're able to make the curve small enough that we can then transition them into a brace with the hopes of them getting them out of a brace after a year or so. Or they just get to the point that they've kind of plateaued, we're going to put them in a brace, expecting that sometime in the future, a few years in the future, we'll have to do some sort of surgical operation for them. And what we're trying to do is take some of the rotation out of the spine. So we looked at those x-rays before, we saw the side-to-side curve, but what you don't get a sense of is that there's also a rotation that happens to the whole chest. So if my fists are the spinal column, or the vertebrae, and my forearms are the ribs, what happens with a curve is that the chest starts to rotate. The spinal column rotates, and when it does that, it kicks some ribs more to the back and some ribs more to the front. So this is a person bending over, they're looking down at the ground, and we do this like so, we're getting the ribs to stick up more, like you're seeing on the picture over here, where here we're rotating, the vertebral column is rotating, these ribs are getting kicked backwards, and this side of the chest is going forwards. So that's what gives you the prominence that you see in these kids when they bend over. And if you were to look at the front of you, you'd actually notice that the opposite chest is a little more prominent in front as well. So this is what the casting table looks like. There's a kind of a flat part of the table that lies under here, a couple of bars that go across, and we attach some straps around the pelvis to pull traction, a head halter over here that goes around behind the neck underneath the chin to pull traction, and we pull some traction and we'll drop the bottom of the table. So now we can get around the whole body here to wrap the cast. And then when we're doing that, we're trying to mold the cast at the same time to take the rotation out of the chest as much as possible and straighten out that curve. So this is a success story, and I have to say this is probably my only true cure in arthrogryposis. This is a boy who at 2 years of age, we started casting him. He's got Sheldon-Hall syndrome. We did a number of casts on him, and we got his curve down significantly. So it was a 40-degree curve, and 5 casts later, it's down to a 22-degree curve, and we were able to keep him out of, after a year and a brace, we've been able to keep him out of bracing since that time. Let me explain a little bit about those numbers. So most of us have no curve to us. If we don't have scoliosis, our back is completely straight. Up to about 20, 25 degrees or so, we will observe curves. If they get over 20, 25 degrees, that's when we want to start to treat these curves. Looking at the far end of this, what are we hoping for? Well, we're hoping that when the child is done growing, the curve is under 40 degrees. Because kind of a rule of thumb is a curve under 40 degrees in someone who's done growing, that curve has a 95% chance of not getting worse. Only about 5 out of 100 will get worse in adulthood. Whereas if the curve is 50 degrees or more, 95% of the time the curve is going to get worse. So very few of them will stay stable at 50 degrees. And between 40 and 50 is a little bit of a gray zone. So I have a 2.5-year-old boy with a 40-degree curve. Ordinarily, that's a very worrisome thing to find. Whereas when we get to 4 years of age, the curve's only 22 degrees, pretty comfortable with that size curve, if we can maintain it. And I always like to say that casting is survivable. There's plenty of parents who have fun with their cast and they can get through it. But it's certainly a tough time. Now here's a child, so here's this girl at 13 months of age, she had a 37-degree curve. Now it says supine, that means we couldn't actually get a picture of her sitting up because she was a very hypotonic child, so we can only get a picture of her lying down. But it was this big curve, and we spent a number of years casting her, but slowly that curve got bigger despite the casting. So this is the other extreme of what happens. I'd say that most of our patients are kind of in the middle, that we're able to get the curve down probably about 20 degrees or so and hold it like that so it doesn't get any worse as they're growing, and then at about 5 or 6 years of age, get them into a brace. But there are variations in how they can all react. So what about bracing? Well, so bracing is for curves that the kid's too old for casting or not appropriate for casting, and they're over about 20, 25 degrees. But all the brace can do is stop a curve from getting bigger, and that's at best, it's what it can do. So a cast can make a curve smaller, but a brace can really stop it from getting bigger. So here we have a child, you see on the left without the brace, and on the right she's got the brace on. You almost get this idea of that you're taking this tube of toothpaste and you're squeezing in the middle, and that makes the tube get longer. And that's kind of how it worked for her. But you're just trying to support the brace, support the spine as best as possible. It tends to work better for the curves that are more flexible. So if you take the kiddo and bend them from side to side and they bend well, that's one that's going to do better in a brace compared to the ones that are very stiff. And that's what, so on the far left is what she looked like out of her brace, and there she is in the brace. And you see it also gets her to sit up a little bit straighter on those two right pictures there. So here she is at 2.5 years old, a 40-degree curve. We're able to bring the curve down only about 10 degrees in the brace, but it bought us a number of years that we could get her to grow. So she was 6 years of age when we ended up having to do something more surgical. We'll talk about that a little bit. In fact, right now. So what are our surgical options, and when do we do surgical options? So I think there's a wide spectrum of criteria for doing something surgical. And I think you also find there's a lot of different ideas that colleagues of mine would have on when to do this. My own preference is that I try to nurse kids as long as possible before I go to doing something surgical. And so when I get to a curve that's over 40 degrees, that's when I start to warn the parents that we're probably going to have to do something surgical at some point. But usually what I'll do is I'll wait until the curve is actually 50 degrees in a brace. So I don't even care so much what it looks like out of the brace, but if I can keep it under 50 degrees in the brace, I'll let the kiddo keep on growing. And then when they kind of tipple over 50, that's when I'll start saying, well, now we got to move towards doing something surgical. But I think there's a lot of different ways of rationalizing when the right time is to do something. And then there's two ways that that treatment kind of separates. One is for someone who's done growing. We're just going to try to get the back as straight as possible and fuse it. And when we're talking about fusing a spine, what you're trying to do is take all the individual vertebrae and make them into a solid bone. So we get down to the spine and we put some kind of fixation into all the different vertebrae. So typically these days we're using a lot of screws. So put a screw into each side of the spine, and then we'll put a solid rod on each side of the spine to connect to those screws. So that the rods help hold the back into the position we want to keep it in. And then you rough up all the vertebrae. So all the vertebrae think they've been injured, and they try to heal themselves up. And as they heal themselves up, they fuse one bone to the next, to the next, to the next. Now, the thing is that we all look at the curves in terms of trying to straighten them out when we're looking at somebody from behind. But it turns out it's actually a lot more important to get them lined up well when you're looking at them from the side. So your profile is what determines how well you're going to do in the future in terms of how comfortable you're going to be. As long as you get somebody's head and shoulders over their pelvis, what residual curve you have isn't nearly as important as having them line up nicely so that when they're walking, they can keep walking upright. And that was a hard lesson to learn. In the beginning of spinal fusions, they did a lot of just jacking people up with straight rods and making them extremely straight. And what they found is as the people got older, they got to the 40s and 50s, they started leaning forward. They started losing their lordosis just by natural process. We all kind of lose it. They started leaning more and more forward and having more and more pain. And there are people who have whole careers out of just correcting those late deformities. So that's one of the things we have to keep a mind on. So the growing kid, we do a spinal fusion. What about, or sorry, the mature person, we do spinal fusion. What about the growing kid? Well, there, if you have a very big curve that you can't control any longer with bracing, then you have to think about something that you can do to grow with them. You don't want to fuse a spine on, say, a 6 or 7 year old, because you'll have a nice straight back, but when they're all grown up, they're going to be an adult with a 5 or 6 year old sized chest. And that's going to be, again, you're going to squish the lungs a lot, and they're not going to be able to get enough oxygen into their blood to be able to be active and healthy. So what you want to do is try to keep up with the growth of the spine, keep extending the chest as they're growing. So there's a few different ways that we do that. So one way that we don't use as much anymore, but this is one of the first ways that we started doing, is something called a vertical expandable prosthetic titanium rib. And what this does is actually attaches to ribs at the top of the spine and either ribs at the bottom or the spine itself. And you have a mechanism that you can adjust. So you see this little gap over here. This one doesn't have much of a gap, but this one does. But what you can do is go do a little operation, remove a locking clip, stretch things out a little bit and put the locking clip back in again, and then let the patient go on their way for another 6 months and keep on doing that. So you keep on trying to stretch out the spine over time. A similar technique is this one here, where we actually grab the spine at the top, either with screws or with hooks, and then grab the spine again at the bottom, and have a similar system over here where we have something we can expand out. So we have two rods across each other. We have a little linker here. We can disconnect the link and stretch things out each time. So every 6 months we go back to the operating room. And this worked pretty good, but it does mean going back to the operating room every 6 months. And even if it's for a small operation, it's usually an outpatient operation, that's tough on the kiddo. It leaves room for getting a wound infected. And so, is there a better way we can do things? And luckily, in the past 5-6 years, we've come up, or a company has released this wonderful mechanism called the MAGEC rod, or the magnetic expansion control rod. And the whole idea is that you now have a rod that you can adjust from the outside. So here you have this child, 24 months old, 78-degree curve. At 5 years of age, it's still a very big curve. So we put in these two rods here, and what you'll notice is that they have kind of a swelling over here. Well, this part over here, the part that looks like a little bullet, so it's down low on the left one, up high on the right one, this has a magnet inside of it. And you put an external magnet on them, a magnet that's attached to a little motor, so the magnet can twirl around the circles, and that makes the magnet inside twirl around the circles also, and that actually drives a little rod on the inside of the rod to get things to expand. So that's what the external magnet looks like, this device over here. We can do this right in the clinic. It's pretty comfortable. So you have this young lady here. Here she was embracing. I had a slow progression and said, okay, you have to do something about it. So we got her MAGEC rods in here. So here that's that little internal magnet here. And you'll notice now there's a little bit of a gap there, so that as we start lengthening her out, you're starting to get this whole device here to expand. And that's why you're getting a little clear spot over there as the internal side is starting to expand out a little bit. And so now, instead of doing it every 6 months, we could do it every 3 months, which is a little closer to what normal life is, and try to expand them out that way. So here we have somebody did 2 years of casting on this 5-year-old, big curve, put the MAGEC rods in there, and then we're able to expand them out. So there he is at 7.5 years of age. Or this young lady here had a big curve. Now this is, not only did she have a big curve, but she also had a big chest deformity. So we couldn't put a rod on both sides. We could only put one on one side, on the inner side of the curve. So we're able to do this, and that allowed us to kind of slowly expand that out. And by doing that, getting some straightening, how do I do this? Here we go. Get some straightening of the curve that way, as we did that. And the whole idea, again, is not so much to end up with a straight spine. It's great if we can, but try to get some more symmetry between the lungs. So if I go back a little bit, you notice that over here on her, she's facing away from us over here. So this is her left side. You'll see there's barely any left lung that you see over here, and the right lung is very collapsed down. And so when we put our rods in here, we certainly do not have full symmetry, but at least now we've got a little bit of a bigger lung over here, and this lung is closer to the height of this lung there. So trying to get some more symmetry in the chest, and that's, again, one of our primary things. Going the right way? Yeah, all right. So now let's talk about spinal fusions. Actually, let me finish up this part a little bit. So what do you do at the end of this? We've gotten somebody, we've been trying to expand them up as much as possible, and now they're pretty much at the end of growth. What can you do? Well, the typical thing that we have always said is that we'll go back to the operating room, take out these rods, and do a formal fusion. But what I've had some success with is in people who are otherwise well-balanced and they're pretty happy about their shape, is just going to the operating room, taking out these MAGEC rods and putting in solid rods and just closing them up again. So through a small incision, it's usually just an overnight stay. And the reason that we think we can get away with this is that when you do these kinds of things, when you put in these expandable rods, it's a little bit of a injury to the vertebrae and the little joints that connect one vertebrae to the next. And so those joints start to fuse themselves up over time. And you get to a point that you can't expand them anymore because they fuse themselves down. So at that point, we're saying, well, why don't we just let nature take its course? We'll put some regular solid rods in there and let nature fuse up the rest of the spine. And for the most part, that seems to have been working pretty good. If we have somebody who is a little bit off center, then we should go do a good fusion so we can get them lined up nicely. But otherwise, I think just graduate them by putting in some new rods works nicely. All right, so what about somebody who we didn't have to do any kind of expandable device? We've now gotten them to just about done growing. What do we do there? So that somebody's got a curve that's more than 40 or 50 degrees when they're done growing. And what we want to do is not only, like we said, make them look as good as possible when you're looking at them from the front or from behind, but more importantly, we want to get their side profile correct as best as possible. And we hold them in place with a rod down each side and a combination of hooks, wires, and these days more screws to grab the vertebrae to line them up well. So here's a 16-year-old with a large 96-degree curve. But what's more important is that her pelvis, here's one side of her pelvis over here, and here's the other side. We call that pelvic obliquity. Instead of the pelvis being flat to the ground, it's very much shifted up because this lower curve is really pushing her over. You see, that's where the pelvis lies right there. So the goal of this surgery is not only to get her balanced, but also get her pelvis flat to the ground. So in this case, not only did we fuse her back, but we also went all the way down to the pelvis so we could grab the pelvis and bring that down to a flattened position there so that she can sit more comfortably. She's not a walker, she's only a sitter. So we want to be able to make sure that she can sit comfortably and not to put too much pressure on one side of her tush. And that's my whole talk. Goodness, I'm done much early. Thank you. And I don't have a wireless mic, so anybody have any questions? And if you do, then be proud and shout. No, that's not a loaded question. It's a very good question. And it's also one where we don't nearly have enough information. So we have now some registries looking at adults, trying to get adults to tell us about themselves, where we hope to understand those things more. Spine, to my understanding, there's probably people in the audience that could probably put me straight on this, but to my understanding, spine is not one of the chief causes of pain in adults with arthrogryposis. More we're talking about ankles and feet and hips and things like that. But just at this conference, I had somebody come up and say, yeah, you know, I did pretty good at a little bit of scoliosis, but now I've been told I have spinal stenosis and I was having some pinched nerves and things like that. So it's, there's probably more susceptibility in adults with arthrogryposis to have these issues than in, you know, the typical population, but we just don't know what the numbers are on that or what needs to be done for them. So good question. So how's your, sorry, son, daughter? She, sorry. So is it ankylosing spondylitis that she has? Really? Okay, that's interesting. And did they think that syndrome also related to her arthrogryposis, or? Yeah, yeah. So if you could email me some information on that sometime, just because I was trying to find. Oh yeah, but I mean, those are the ones that help define kind of the edges of arthrogryposis that we need to understand. Dr. Heyer. What Dr. Heyer's saying is, how do you look at hip contractures at the same time as somebody who's got a scoliosis, particularly like Dr. Heyer's saying, those hips kiddos who don't sit, whose hips don't bend up well, so they actually compensate through their lower back to sit. So if you fuse them, suddenly now they can't sit. And is this a walking person or not a walking person? Oh gosh, you're really making it hard. Because if it wasn't a walking, sure. Right. But and then of course you get the issue of, well, if it's a 60-degree curve, 50-degree curve, I might say, well, let's watch and see if we're that lucky 5%. But if it's a 60-degree curve, that one is certainly going to get worse. So you need to fuse it. So then what do you do? Well, then I would say I would first try to address the hips to get them to bend up well. That's the way I look at it. Other people have different philosophies before I go and try to fuse the back. But yeah, if it's somebody's not walking well, that's much easier. Just get the hips so they can bend up and they can sit, and then we're done. But if it is somebody who's walking, you don't want to take that away from them. So then Dr. Heyer and I have had conversations before about what do you do for people whose hips don't bend up, and that's for me an unanswered question in arthrogryposis, and we keep on trying to explore that one. Yes, ma'am. So I think at 11, you're at an okay age for doing that. Have they been able to expand those rods, or they have been? But then I would, from where I stand, I would say keep going with expansion. Try to get as much as you can out of it. If they get to a point where the rods don't want to expand anymore, then there'd be probably a point where you'd have to go and do the fusion. Okay. Okay. Well, you guys are keeping me on toes. These are all very tough issues. So the in part what you're talking about, and let me break it down to the audience. So what mom is saying over here, she's got a child who's got a pretty good size curve, 60-degree curve, but more importantly, she's got a big kyphosis. And one of the issues we've gotten into when we use the MAGEC rods and you're trying to lengthen somebody up, sometimes what happens, instead of making them straighter, you're making the part of the back straighter where the rod is, but the part above it just keeps on bending over more. So actually, if you go from the pelvis to the upper part of the front of the chest, this part's not getting any bigger. The back of the back is getting bigger, but the front of the chest is not getting any bigger. They're just kind of curving over more and more. And then what happens is you start losing connection with the spine at the top. The rods, the hooks pop out, or the screws start pulling back. So yeah, if she's 11, then I would probably go in that direction also, saying, well, let's just get a final fusion going. Because you're probably right. I think the more you try to lengthen her out, the more she's just going to kyphose over the top. The amount of growth that she's got left, the numbers that we use as orthopedists for figuring out how long somebody's going to grow is, by and large, boys will grow until they're 16 and girls will grow until they're 14. With the girls, you got a little extra help because they tend to grow for 2 years after they start their period. So it gives you a little bit more information. If you really need some good information, then you get an X-ray of the hand, which has got a bunch of little growth plates on it, and that can also help you judge how much growth somebody's got left. But I think at 11, she might have 3 years of growth left. And if you were then to kind of tip the scales between more complications and more kyphosis versus getting things under control, I would probably go more for getting things under control. Yes, ma'am, I'm back. Okay, so another very simple question here, huh? All right, so part of it has to do with how far down your back is fused. So we talk about, this is the cervical spine, your neck. Your chest, where the ribs come off, is your thoracic spine, and then your lower back is your lumbar spine. So the thoracic spine has got some motion, but not a whole lot. And if you fuse people in the thoracic spine, they're probably not going to lose a whole lot of motion and not be very upset about it. The lower you go into the lumbar spine, the more motion you lose. Now, if you fuse about half the lumbar spine, you're still doing pretty good motion. If you get down, so there's 5 vertebrae there, L1, L2, L3, L4, L5. If you get down to L3, you're still doing pretty good motion-wise. You get down to L4 and you start losing more and more motion. So that's one thing. In terms of the muscles are long muscles. So if you're just fused, you're talking about, if I fuse this segment here, what have I done to those muscles? Not a whole lot, because they're long length muscles. So those you can keep strong. Your core muscles in front, you can keep strong. Now, if you don't have a lot of motion there, then those muscles aren't doing a whole lot, but they're still helping in some way with balance. So even somebody that you go down to the pelvis, arguably those back muscles and those abdominal muscles are still doing some work in balance. But the shock absorber part is actually in the front of the spine. That's your discs. So those are the shock absorbers. And the more you fuse into the lumbar spine, the more stress you're putting on those discs that are still mobile. So if when we fuse them back, we don't do anything to the discs at all, other than stopping the vertebrae from moving. So you got 2 vertebrae that don't move anymore, and the disc in between, it's just not getting normal nutrition. It starts to kind of fade away, and down the long road, you may actually get the vertebrae diffused in front there. But the other ones that are lower down, those are having to compensate and move more. And yes, there's a higher rate of those wearing out and getting disc herniations and things like that, but not 100% by any means, but we certainly know that they're more at risk. So what's the important thing? Well, to do just good back maintenance. So we always talk about how you're supposed to pick things up. For most of us, that means you got to bend your knees more than you bend over. You got to be careful how much you bend over. You want to also keep exercising, so you keep things moving around, because that's healthy for the discs. And I'm just gotten okay, that was okay. So I'll be out in the hall if anybody's got any questions, and thank you all very much for attending.